Welcome on behalf of the Sugar Queens. Hello. Thank you for joining us this month. I'm Eden Miller, an osteopathic board certified family practitioner in Bend, Oregon. My queens, introduce yourself.
Hi, I'm Jennifer Goldman. I'm a professor at Mass College of Pharmacy in Boston and a clinical pharmacist at Well Life Medical in Peabody, Massachusetts.
And I'm Davida Kruger. I'm a certified nurse practitioner at Henry Ford Health in Detroit, Michigan, in the Division of Endocrinology. I do clinical research and clinical practice, and I'm thrilled to be here today.
We are all thrilled to be here, and we are so excited that you have joined us. For the next 30 minutes, the Sugar Queens will present and discuss the benefits of using CGM in an older individual with type 2 diabetes that isn't on insulin. Wow, right? Right? Seriously, what a case. You know, Jen, what are you most interested in today's case that us Sugar Queens are going to be discussing?
Yeah, this is something, and we talked a little bit about this last time, older individuals. So I think I'm most interested in talking about the time in range and A1C, and do we change some of what our goals are for that population? So how do we use that in an older individual?
That's awesome. Davida, what are you looking forward to?
Well, I think it's really important for us to point out that when CGM first came to market, we only thought about it for individuals who are type 1, maybe on insulin pumps. And now we've realized that there's behavioral changes, there's all kinds of things that our patients benefit by if we can use CGM in the early phases of type 2 diabetes, and people don't need to be on insulin to benefit. And there shouldn't be an age upper limit, and certainly they're not complicated, so at any age people can use them. And then the final comment I would make is we're using all kinds of great new medications that don't cause necessary hypoglycemia, so that isn't the only thing we use CGM for. In the past, we only used it for prevention of hypoglycemia. So the goals can be tighter.
So many great topics. I mean, I love it. We are already diving in. I want everybody to stick around, but also we need you to join us in this conversation. We're here for you guys. We want to make this relevant. We want to make sure that you can see the benefit of CGM, so you guys can see how it goes beyond just hypoglycemia control and insulin. And so without further ado, I want to jump in. Queens, this is one of my patients. This is an individual who sees my husband. You know, he's the other Dr. Miller. I don't call him the king, but he definitely is in the Queen's court. And he sent this case to me. We are in private practice. He's a 76-year-old man that has type 2 diabetes. He's a retired mechanic. He's on the accoutrements, right? Losartan, atorvastatin. We're treating his hypertension, his hyperlipidemia. But I want to remind you, he doesn't want to be on those expensive meds, right? He chose metformin. He chose pioglitazone. We don't have heart failure in him, but he chose these meds. And yes, I got him to go with empagliflozin because of his cardiovascular risk and, you know, kidney advancing age. And I got him on that patient assistance. But, you know, he came in and he was doing sporadic finger sticks, and he was like between about 110 to 145. So my sweet husband, who's learned from us Queens, said to him, hey, do you want to engage with your diabetes at a level that, you know, can maybe reveal what happens when you eat or when you have different things in your life regarding your diabetes, such as lifestyle and exercise. And, you know, maybe we could look at this, because he really was not hitting his goal. He wasn't hitting his goal. And so what we decided to do was kind of offer CGM. Now, let's take a moment for a second, because we're kind of outside the, how shall I say, standard of care for the ADA. So before we go into the exact things that he's going on, I want to comment on that. Okay, so let's go around the horn, because some people that are listening are like, well, he doesn't really qualify or get it covered. So Queens, answer that question a bit.
Well, you know, Davida, you just said originally with what you wanted to talk about is spot on with this person.
Yeah.
Is that just because they have type 2 diabetes and they're not on a drug that increases the risk of hypoglycemia, that doesn't mean CGM should be withheld from that person, because everything that we learn from that. And this patient that you pointed out, has blood sugars with finger sticks that sound good, but we don't know. Those are 2 moments of time. Even if he's doing it twice a day, maybe those 2 moments of time, it's fine. And it's not a reflection of what's happening all day.
And I think we have to talk about what is an older individual. Is 76 really an older individual? I personally am offended. But I also think that the better job we do, our patients are living longer with diabetes. And if you look at the population of greater than 65, that's the greatest growth of people with type 2 diabetes. So we really need to get ready for the best way to manage these individuals. And so, and we did the wisdom study, and I know that was in type 1, but we did it in older individuals greater than 60 years old, and I believe up to 80 years old, we included people. And it was to show that those individuals would benefit by CGM, and they did. So I think we have to get past what the idea is. Maybe we adjust the goals, maybe we choose different medications, but everyone deserves to be on CGM to help them with behavioral changes and other things so that they own their own diabetes. So I don't know that this is actually not the same as what the ADA is saying, because they have their whole hierarchy of, definitely give it to these people, definitely give it to these people. Maybe we should give it to these people. Rich Bergenstahl just did this step ladder thing that showed, and then where do we need more research, or we think these people would benefit by it. So I'm in the camp that all people with diabetes would benefit from CGM, but for different reasons. So if you're on an insulin pump, that's one reason. If you have type 2 diabetes, older individual, not on insulin, you're still going to benefit from it. And we should offer it to those individuals.
And we know that glycemic control improves outcomes, right? Microvascular outcomes. So why are, these people at that age, they're living longer, like you just pointed out. So why not live healthier longer?
Yeah. Exactly. And then it kind of goes to goal. One of the things I think of the past is we had higher expectation goals or A1C targets for older individuals because a lot of the drugs we used were hypoglycemic drugs. Yes. And it wasn't really the destination A1C per se, it was how we got there. So let's dive in a little bit more. Let's look at him when he came to the office, because his presenting A1C was 7.5. So it was 7.5. We want to get him to A1C less than 7. All 3 of us queens are going to say, we're not going to let inertia continue. We're not going to sit here and say, oh, that's good enough, pat ourselves on the back. I suppose it's good enough. He's older. But the reality is he's asking, what do I need to do to get me to an A1C of less than 7? We did talk to him about GLP-1. I know you're all are thinking that, GLP-1. Yes, we're all pro GLP-1 here, but I got to pick my battles. And he was asking, how does lifestyle affect it? So he agreed to do a trial. So what we did is put a CGM on him. He agreed to do a trial. We knew that by technicality, it wasn't covered by CGM today, maybe the future, because he isn't on an insulin shot. He doesn't have chronic kidney disease. He might have a little CAD. He doesn't have dexterity issues. He's not a hypoglycemic agent. But what we did is we applied a CGM in clinical practice. We gave him a journal to say, let's look and see what the effects are of lifestyle and medication adherence. I want you to journal it. I don't want a novel. He was willing to put that cost up front to just look at it. And we said, hey, come back and we're going to go through it. So let's dive in quick to review before all of you are like, I can't do that. What do we do? Let's review the Medicare coverage for CGM. So Jen, go into that real quick to remind our listeners of how we remove barriers for acquisition.
Yeah, so right now for Medicare, it's covered if you're injecting at least one insulin injection. So, that's not optimal for everyone. So often, I'm able to get some samples and I might put one on as a sample and then have discussions with that patient, whether they could afford to purchase one sensor or multiple and just put it on before their appointment with me, or they put it on, learn what they need to learn, and then do it once a month or once every few months. I think things will be changing, and I know Davida knows a lot about what's up and coming with Medicare.
Well, one of the other things that Medicare will cover is if they're not on insulin and you've made efforts to adjust their medication and they're still having hypoglycemia and you can document that, or they've had an assisted, they will also do that. So that means, though, that patients on, a sulfonylurea, and perhaps we don't want that either, but if they are, that would be coverage. And so we've always said, if you have Medicare, 100% have to go to DME. And now some of the policies are changing, and they don't care about type 1 or type 2. It's insulin or hypoglycemia. And so you might have to look at your policies locally, and some of them will be going to pharmacy. So it's going to get very crazy in terms of what it is and what it isn't. But what I usually say is, if you think it should be covered, you've written the prescription, you send them to DME and it doesn't get covered, try pharmacy. If you send them to pharmacy, try DME. But things are changing. And the other thing too is that there's now over-the-counter CGM.
Yes.
So that's totally exciting. At first, I wasn't sure, and I'm very, very excited about that, because if the patient doesn't qualify, the over-the-counter will be, they don't need a prescription, and they are cheaper than if they were paying cash for the CGMs than we're used to. And there'll be two coming out, Stello and Rio, and the patient can choose what's best for their life. The only thing I would say is that it is a 15-day sensor. So perhaps you don't need to wear 2 a month. Maybe you wear 1 a month and alternate months, or something that works in your lifestyle. But hopefully that would be affordable for most of our patients. They don't have alarms, but we as healthcare providers can still see them online. They can connect to us, and there's no readers. They have to use them on their phone, but it's a wonderful option. And again, if you go back to thinking about all people should be afforded the opportunity to wear CGM, it's a right, not a privilege. And that the patients get to choose how they want to spend their money. This is awesome. Awesome.
Yeah, game changer. Definitely.
For sure. Hey, let's take a look at what happened to our individual in a mere 4 weeks. So in a mere 4 weeks after we place the CGM, we do a follow-up appointment. Remember, we don't want inertia. If you get a CGM placed in our office, you get a follow-up appointment in 2 to 4 weeks that says CGM interpretation. That allows my staff to understand what's on the docket, to make sure it's connected, download, and get ready for this. So we brought them in, and this is how I like to tee it up every time. They come in and I say, what did you learn? What did you learn about your life? Tell me. This is not a shame or blame. This is not, I want to know what they learned. I often talk about the fabulous 5 foods, the 5 foods that don't affect your blood sugar. I talk about the forbidden 5 foods, the 5 foods that you had no idea were going to affect your blood sugar. And he said to us, just like you all see, I had no idea how this affected it. I had no idea. Again, it doesn't cover it, but I asked him, what do you think about continuing to use this? And he was like, you know what? This is really good. So Jen, dive into a little bit about a unique scenario of this individual who sees the benefit, and what are some of the different ways to kind of encourage it, or maybe utilize things, or how can we continue to use this on an intermittent basis? And why does it help?
I want you to tell us about the 5 foods.
Right? The Fab 5.
The forbidden ones.
The Fab 5. Yep. The
What's
one.
the other? What's the other 2?
The Fab 5 for me, because as you know, many of my queens know that I have diabetes. My Fab 5 foods is fresh pasta does not bother me for some reason, right? My forbidden 5 is if I even look at a bag of granola, I'm dying. It's just terrible. So that is what I see as a person with diabetes, and we see it over and over again in our practice. You don't necessarily know. I'm not saying orange juice doesn't raise everybody, but you do not necessarily know those foods that are sabotaging you. How many of us here in the Queen's, reign heard about oatmeal that the person thought it was healthy?
Yep.
Now, I'm not saying it's not good for heart disease or fiber, but come on, it's massively elevating these blood sugars. So talk to us about intermittent use, how you get these people going. What do you do in your practice?
So that's a perfect example. What you just said is that this patient now had that 2 weeks. is able to learn, when I eat this, this is what happens. And it can be a big surprise because, you know, they go into the healthy section in the supermarket and there's the granola, right?
Yeah,
There's
right? It must be good for me.
rice, that's wonderful. So, and if I'll eat brown bread instead of white bread. It won't do anything. So I think that one of the most wonderful things that patients learn, even with intermittent use, is understanding when I do this, this is what happens. And you know, let's not forget, when I take a walk, this is what happens. Or when I, you know, activity, this is what happens.
Or when I stay on my meds.
Yes.
Right?
Oh,
yes.
Absolutely. When I don't take insulin dose, so when I take my pills.
Don't take my metformin with dinner. Like, how many times have I seen that? This is also, you know, I had an interesting encounter, and I'm just going to tell you real quick, because I had an opportunity to talk with a little bit of our colleague who was a bit of a lagger. We'll forgive him. He's a little bit of a CGM lagger. And he was saying, I don't know why you guys are so excited about these CGMs for people that aren't on insulin. And I said, wait for a second. I said, sir, are all of your persons in your practice adherent to lifestyle, adherent to exercise? They know what the effects of their medications are. They know what the effects of their choices are, and they feel empowered to deal with their disease. And he said, no. And I said, then I got a tool for you. Right? Exactly. So let's go to the AGP real quick, because I want you to tell me, Davida, what you see. So we're going to go to that AGP. This is day one, right? Remember, he started out at 7.5. 7.5 was his A1C. I know it's a 3-month average. This is 4 weeks later. What do you see, Davida?
Well, he's, you know what, 90% time in range, which is phenomenal. And with little to no low blood sugar, which again is phenomenal. And I see that most of his data is where it needs to be, with little poofs after his meal. And those are
little poofs. Did you call them little poofs? Okay.
F's, poof.
Poofs. Yeah, little poofs.
Yes, little hills, if you will, little poofy hills after his meals, which may be perfectly acceptable. Or again, it gives him an opportunity to think about what he's consuming. And, you know, I the only things I get rabid about is juice. I don't know what to do with
right?
Juice.
No liquid carb.
Yeah. In fact, if I'm at a restaurant and someone orders it for breakfast, I try not to introduce myself to tell them why they shouldn't drink it. But and I don't even know these people, and I probably don't have diabetes. But I think that it's a matter of him learning what foods cause those little hills. And if he's either not eating lunch or lunch is perfect, but they may be perfectly fine when you see the time in range. This is phenomenal. Yeah.
Hey, Jen, tell me about GMI. Tell me about GMI. I love GMI. Tell me why you like GMI.
I love GMI. You know, it's very enlightening, especially if someone makes a change. But to be able to say, if we were doing it, so what I explain to a patient is, if we're looking at an A1C, which is a measure, an average over 3 months, this is an average over 2 weeks. So for the last 2 weeks, you're now at 6.6 instead of 7.6. So, but I do think we can, you know, drill down a little further and even see what's happening. But I have a comment about the orange juice, and I always feel guilty if I take a sip of orange juice. So what I'll say to patients is, how about you eat an orange instead? Try eating.
Exactly.
So don't drink your food. Eat your food.
The fiber in the orange is better than the juice.
Yes.
And I want to go a little bit further on GMI, because it's one of my little button points. Sometimes, you know, I've seen presentations that go an hour on glucose management indicator, and they want to talk about its reliability and whether it is the A1C. I like to look at it in different ways. One of the things that I like to look at is, I call it the add a girl, add a boy metric. And so you're right. You know, we had an A1C of 7.5. He comes in right now and his GMI is under 7, which is our target with him. We also notice he's not getting hypoglycemia, but why would he? He doesn't have any med that's driving the hypoglycemic bus, so we're not going to be as worried. We're not using CGM to prevent or identify hypoglycemia. That's not our purpose. Our purpose is to illuminate all the different places he goes in his glucose journey, because he doesn't know how he gets to his destination. And maybe he gets lost, and maybe he comes here. Not only that, he was blinded to his own glycemia. So he had no idea the effects of foods or that kind of thing. So the GMI to me is the atta girl, atta boy.
Yeah.
And that says, look at the change that you did in this short period of time. And if you sustain this over time, that means those changes that you do, yep, just like you said, Davida, it's going to sustain over time. And then you're going to get that A1C credit at the end. And so some of my colleagues are like, oh, it's not that. I'm like, it can be, because have you guys ever seen the GMI very close to the A1C at times?
Yes.
Sure.
Over time, it will get there.
We have to keep in mind the time in range. So similar to what we talked about in the first, episodes, that you can have averages with highs and lows, but your patient's time in range is spectacular. So we expect it to have that good GMI and be, a low glucose variability. So
Yeah, for sure. Right. You put up a really good point. When you improve glycemic variability, variability is consistency. It's not good or bad. It just means you're consistent. And you do that over and over and over again. That's when your GMI tends to do it. Hey, we're almost done with our wrap up here. I just want to tell our listeners, please put the questions in the chat. I know you guys are having questions. We want to get to that in just a few moments, looking at your questions, diving in. The Sugar Queens want to talk. We love it. You can tell we love to talk. But Jen, you mentioned just a moment earlier about the effects of his glucose based on a day by day. So I want to put up that daily modal, which is what we call that daily profile, right? What do you see here in week 1 and week 2? Because this is where it gets real.
Wow.
Yeah. So when you're looking at an AGP, everybody, we've kind of gone over that top part, but if you look at the daily glucose profiles, this is where you can identify on a day-to-day what's happening. So like in general, you might say, wow, look what happens on Saturdays and Sundays. What are you doing on the weekends? But for this patient, you can see on Wednesday and Thursday, that's where, he had these very high postprandials. And each day, even Friday, but each day it's better, but definitely week 2 is better than week 1.
Well, after day 2, and you look at day 3, it's already coming down. And so whatever he was doing on day 1 and 2, he said, whoa, that doesn't work for me. I'm going to make a change. And then on day 3, he said, well, better, but not there. And then the rest of the time is beautiful. And if you think back to the AGP, when I was pointing out the after breakfast, and you saw most of it was together, but there was some fuzzy clouding above it, that's your couple of days. And if you take day 1, 2, and 3 out, wow, he's there. That's gorgeous.
Yeah. I'm never going to forget sugar poofs. I'm going to put that in. You're having a sugar poof on your AGP. I'm going to do that. And so let's go one step further. One of the things that we mentioned at the beginning of this is I had him journal. And, go back into the Fab 5 and the Forbidden 5, because some of the persons think that they can't eat at all. And this is an empowerment tool. And so then I took it one step and I said, what foods did you notice? What foods did you notice that affected you? This is that individual decision making. And some of it he was quite surprised with. He had no idea those particular foods. We can see an immediate change. Some of my colleagues think that this is a shame and blame tool. No, it's an empowerment tool. Yes. You are bringing the patient into the control of their disease. I often say that we need to equip patients to be experts on their own disease. And this is a tool that helps them be an expert. It's the difference of diabetes having them and them going around not even knowing how it affects them versus them owning and having diabetes. This is an empowerment. And that's why we have a whole series dedicated to CGM. That's why we get so excited every month to talk to you. That's why we sometimes say, why are you not doing this? Come on, people. Over the counter's coming. You got to be ready. And what a joy. What a joy, because when he came back, his GMI was 6.8. He said, I want to keep using this. I told him we could do it intermittently. We could do it continuously. We could do it continuously for a time and intermittently. And you know what he said? He was willing to pay cash for it in the current climate with CMS, but we may not have to do that in the future. We might get a little save in a few months with these over the counters. So wrap us up, ladies, and then we'll go to Q&A.
Well, I want to, I'm sorry, Davida,
Go ahead, Jen.
is that I have seen, in practice so significantly with the use of CGM, people really lowering their A1C by 2-3% just from diet, just because the CGM told them this. So what you just said and what Davida educated us all about in terms of over-the-counter CGM coming, I think that this is really going to make a lot of changes out there.
Yeah, I think there's enough data to support exactly what you have just said on all of the devices. Our published data that shows without making any medication changes, just providing a CGM, and these are individuals that are not on insulin, you can see as much as a 2 to 3% lowering of the A1C because it opens people's eyes. And exactly what you're saying is that they get to own their own diabetes. And I think that's really important. And we can't be the food police or the exercise police. And you guys know that I've stopped going home at night with my patients. I let them just go home.
Good.
And so I want them to own their own diabetes. And this is exactly the best way for them to make behavior changes, own their own diabetes, and have a better outcome. And you know what? If you are not in a clinical practice that's using CGM, your patients are going to be using it and they're going to know more than you are. So you do have to get on the bandwagon. And I don't know how do you think in practice without using CGM. It's lost. I mean, I'm just lost if I don't have the data to support, and then to have those great conversations with my patients.
You're absolutely right. And you know what? Looking towards the future too, we're doing a lot of work in early diabetes. These over-the-counter are going to help identify people at risk for developing diabetes and using it as a risk identification, risk reduction. And so we're coming to the end of our content conversation. We always take your questions to the very end, but we want you to understand. We want you to like us and subscribe and keep coming back. Scan our QR code that we're able to have to continue the conversation, to go back in some of our archived ones, to look forward to our next topic, because the queens are not done yet. We just love bringing this educational content to you. And queens, I just want to let you know, we don't have any questions, but we have so many loves and likes. Great information. Thanks. Keep it coming. And so to claim your CME and CE credit, we want you to scan that QR code. We love that you join us just because you love us and like us, and this is beneficial. But we also want you to go away from that continuing medical education credit, CE credit. You can go at our archived ones anytime. The queens love you in person because we love to feel the love and to spread the love. And so we want you to put on your calendar for the next time so that you'll join us. And so, queens, thanks so much for going through a topic that's a little bit outside our typical view of this. At the very end, before we do got a question, queens. Do we think that continuous glucose monitoring could be something in an alternative medicine realm? I'm going to assume I know what alternative medicine means. What I mean by that is maybe utilizing behavioral lifestyle changes instead of medications. I'm going to say, of course.
Of course.
But wrap us up with your answer.
I would say absolutely positively, and will be not only yes, but doing it sooner before A1C gets out of control, preventing complications, using it in early diabetes, and whether you use that term or pre-diabetes, why not? And there will be shortly another CGM that is dedicated just for the patient without diabetes who needs to make lifestyle changes.
I'm going to add two. So I wrote a paper on alternative medicine for diabetes. And so there are alternative meds out there that will help with insulin resistance, lower your glucose. But, evidence-based medicine is near and dear to my heart. And so if we do know that we have data on the drug therapy that we have,
Mm-hmm.
that
Mm-hmm.
if you have heart failure, if you have ASCVD, if you have chronic kidney disease,
Well,
we know that these certain drugs improve the outcomes. So my thought on alternative medicine is it's perfectly fine in addition to proven drugs that have those outcomes, and a CGM on so that you know what it does, because you might have to lower the doses of something.
Well, with that, thank you so much. On behalf of the Sugar Queens, we appreciate your participation. We look forward to seeing you next month in September to share our tips of overcoming barriers to CGM. You don't want to miss it. Goodbye.